Welcome to Health Matters, where we explore key topics from a primary care perspective. I'm your host, Dr. Shay Spencer. Here at Vandalia Health, we are passionate about bridging the gap between primary care and specialty medicine, ensuring that complex medical topics are accessible and understandable for healthcare providers and patients alike. In each episode, we'll dive deep into the latest advancements, best practices, and critical insights to help improve patient care. Thank you for joining me on this journey toward better health. Today, I'm pleased to announce that we have Dr. Andrew Lee with us. He is Assistant Professor of Vascular Surgery here at Vandalia Health. Dr. Lee comes to us from the University of South Carolina School of Medicine in Greenville, South Carolina. He completed his Vascular Surgery Residency at Charleston Area Medical Center here with Vandalia Health, and he has now joined the faculty. He is one of the newest assistant professors. Dr. Lee, how long have you been in that role?
About a year and a half now.
Okay, awesome. Well, we are so thankful to have you here joining us today. I'm also pleased to introduce our other guest, Dr. Go. She is joining us from the University of Pittsburgh School of Medicine, where she later went on to complete a vascular surgery residency at UPMC. And she's also been serving as assistant professor for vascular surgery here at Vandalia for what, Dr. Go? Has it been right around 6 months or so?
Right about 6 months.
Awesome. So we have two of the youngest and brightest here with us today, so hopefully we can learn a little bit from you guys. So more or less just going to talk about a few patient cases that we often have come up, whether it be on rounds or just discussing amongst ourselves. So maybe we can get a little bit of insight from our vascular surgery colleagues. So our first case is a gentleman that is well known to our service, Mr. J. So he is a 68-year-old male, has a history of hypertension, hyperlipidemia, and type 2 diabetes. He also endorses about a 40-pack-year smoke history. He's presenting to his primary care physician for routine follow-up. He reports no recent episodes of dizziness, weakness, or visual changes, but he does mention a brief fuzzy feeling in his left eye. He says maybe lasted a few minutes, and that was about 2 weeks ago. Upon further questioning, he denies any slurred speech or weakness in his arms or legs. His physical exam is unremarkable, except there is a faint bruit on auscultation of his right internal carotid artery. Concerned about the potential implications, one of the residents orders a carotid duplex, which reveals stenosis of the right internal carotid artery at about 75%. So, Dr. Lee, when I'm thinking about this gentleman, I'm already thinking, from a family medicine perspective, starting him on aspirin and a high-intensity statin. But when this gentleman gets referred to see vascular surgery, what's one of the first things, that you guys are thinking about?
Sure. So when I have a patient like this come to my office, I'd really like to kind of talk to him about what these vision changes or the episode that he had 2 weeks ago, to kind of decipher exactly what happened. If it's happened before, if it has happened before, is it occurring more frequently? How long these episodes last? Is it a complete loss of vision in one of the eyes versus just blurry vision or difficulty seeing? And then I'd like to kind of ask him, like, all the things that you've already gone through, like weakness and numbness in one side of the body, trouble speaking, slurred speech, trouble swallowing or eating, and if anyone's ever noticed they've had like a facial droop or some other signs or symptoms of stroke that would be going through my head. So that would be the first thing that I would go in there and talk
So more or less, it kind of seems like you're differentiating whether he is going to be symptomatic or asymptomatic.
That's correct. Yes, because that
absolutely
really changes how I manage this patient.
Absolutely. So with this gentleman with left-sided visual complaint, and he has a right-sided ICA stenosis, does that worry you guys?
So usually if it's visual symptoms where someone's losing vision in one of the eyes and it comes back pretty quickly, it's usually on the same, if we're worried about it, it's on the same side of where the stenosis might be. So
Absolutely.
If Mr. J has a 75% stenosis on his right carotid artery, then for his eye symptoms, I would be focusing on his right eye.
Absolutely.
Rather than his left eye.
Completely makes sense. So unilateral symptoms.
Mm-hmm.
So yeah, you touched on some really important things. So in terms of like helping us care for the patient better, we talked briefly about, aspirin and high intensity statin. What are some other things like you're going to reinforce, like at office visit, or things that we can do to kind of, because I assume that, he's going to be seeing us a lot more than he'll probably be seeing you. So what are some things that we can kind of hone on?
Yeah, so making sure, all his other past medical history is taken care of.
Absolutely.
So blood pressure control, you said he has high cholesterol, type 2 diabetes, so blood sugar control is very important as well. And he obviously has this 40-pack year smoking history. We all know smoking really leads to atherosclerosis and plaque buildup in all the vessels. So trying to get him to cut back or quit altogether would be my next step in management. And then people who have disease in the carotid arteries likely have disease elsewhere.
Absolutely.
So it's very important for us to make sure our patients know that, and if they're not seeing a cardiologist or actually screening them to see if they have any chest pain or angina type symptoms, really trying to make sure that their coronary health is also on par with all the things that we're managing too.
Absolutely. Thank you so much. So from what I'm kind of understanding, just defining whether he's symptomatic versus asymptomatic. If he's asymptomatic, more or less just following him with carotid duplex type of thing. When would you repeat a duplex on him if he's asymptomatic? Falls into that asymptomatic category.
So an asymptomatic carotid artery stenosis at 75% does put him in the severe category.
Yeah, absolutely.
So I would repeat a carotid duplex if I'm just managing this with surveillance in about 6 months, and I'd see him again back in 6 months and see how he's doing.
That's good, and that's important for us. I know one of the biggest things that we try to facilitate on that, aside from medical management and making sure hemoglobin A1C is at that target range less than 7, making sure his LDL is in good range, smoking cessation. It's just making sure that he knows that, hey, you've got a carotid duplex in about 2 months. So sometimes I'll just write the appointment down for the patient, kind of hand it to him. Because it's just one of those things that can kind of fall through the cracks.
Yeah,
so
absolutely.
We appreciate your guys' great care that you provide our patient population. So, we talked about surveillance and we talked about what we do as primary care. Have you noticed any recent advancements in the treatment of carotid artery stenosis that maybe you feel are changing your practice?
Yeah, absolutely. So I don't want to say the traditional way, but the way that typically carotid disease was managed if they were going the surgical route would be something called a carotid endarterectomy, something that's been around for 40, 50 years, been tested, and has stood the test of time essentially with really good results long term as well as perioperatively. Probably in the last 20 or 30 years, carotid stenting has been an option as well. But with carotid stenting comes its own risks that are kind of separate from carotid endarterectomy or surgery. And probably within the last 10 years or so, there's been a new way that we can actually perform carotid stenting. It's almost like a hybrid procedure where we combine a little bit of surgery and a little bit of endovascular therapy or endovascular surgery to combine both an open procedure and a carotid stent procedure. So that's called transcervical carotid artery revascularization, which is a mouthful. So we just say TCAR for short.
Don't ask me to spell that.
Yeah. So a TCAR procedure essentially is where we can make a small incision above the collarbone on the side of where the stenosis might be. We get access to the blood vessel from right where the collarbone is, and we're able to stent it from that little incision that's present there, rather than having to come from the arm or from the groin like a typical carotid stent would be. And that kind of helps minimize a good amount the perioperative stroke risk. And so it's one of the newer technologies and newer procedures that we do. And I say new, it's relatively new, even though it's been out for 10 years or so. It's not been tested as long as a normal carotid endarterectomy surgery would be.
So that is, wow, honestly, that is such good information for us, especially because you see TCAR in the note, but to actually have the procedure explained to you and kind of walk through. So I'm sure that we're going to see more data about that in the future. So
yeah, it really is patient dependent too. And a lot of this, depending on whether they're asymptomatic or symptomatic, discussing treatment options, it really is one of the things that I talk to patients and their family members about. And when we talk about shared decision making, this is probably one of the ones that take the longest to talk to patients about, because there are very real risks when we do procedures like this. And to have that discussion and have the patient on board in regards to what risk they're willing to tolerate versus the benefits of each of the modalities that we can treat this is a pretty cool experience.
Absolutely. And I'm sure Mr. J would be thankful for the care that you provided him. He's so thankful that he's actually coming back to you just about 6 months later. So Mr. J is thankful that he established with the vascular surgery team. He failed to mention that he's had around 6-month history of cramping and aching in his calves that he says occurs primarily after walking 2 blocks. He says it's alleviated by rest. He notes that the pain has progressively worsened over time, and the distance he can walk before experiencing the symptoms has decreased. Can we just cut the part that she did?
Yeah, we could do that, but also if we could just get kind of conversation between all three of you.
Oh, okay.
Yeah,
that's
just,
fine. Yeah.
you know, just make it sound like a conversation.
I do have a case that I need to run to, so
Okay.
we can maybe finish out the scenario with the questions, the last couple questions that we've
PAD.
done.
On PAD?
On
Yeah.
the PAD, yeah,
Yeah.
and then maybe you guys can do aneurysm. I know you wanted kind of more of a conversation group-wise, but I do have to run.
Yeah,
Sorry.
absolutely.
Sorry. No, it's okay.
So let's jump to PAD. And what do I have
I think
here?
I just talked about like the 3, like claudication, rest pain, and tissue loss.
Absolutely.
And that how the 3 of those change
Yeah.
treatment, whether it's surgical or not.
Yeah. Okay, let's see here. Scenario 2. I'm right here. Thank you so much, Dr. Ghost. So, depending on the symptoms, it kind of depends on what you're going to do. And again, Mr. J was describing this claudication that he was happening. So, what are some signs and symptoms that would prompt you to undergo emergent or urgent revascularization?
So claudication is, as you're hinting at, claudication is not an urgent or emergent pathology. He's probably struggled with this. I think you said maybe 6 months now. It doesn't change drastically generally, but something that I would counsel him about is a sudden change in his leg symptoms. Sudden, you think of the 5 Ps that maybe we were all taught back in medical school. Pallor, so pale, cold leg. When it's white, it's lost its,
Perfusion.
Perfusion, thank you. Pain, so just ischemic pain. Paresthesia, so tingling. Poikilothermia, which I always thought was
Don't
a
ask me to
stretch.
spell that one either.
Always a stretch, but meaning the leg is cold when you touch it. Did I miss one? Pain,
Paralysis.
and paralysis.
Paralysis.
Yes,
I knew.
unable to-
Yeah.
Yes,
couldn't remember
exactly. Unable to move their leg. So this would indicate to me that there was a sudden change, like an acute blockage of maybe some chronic stenosis that was already there, and then it just kind of like an MI. It's almost like a leg infarction essentially, where a plaque ruptures. So that I would tell him to seek, emergency care immediately, and would prompt me to operate, or whoever's on call, hopefully not me, to operate that evening, especially with the paralysis and the sudden rest pain. But for someone like Mr. J, who has claudication, I want to dive into that a little bit more and ask him, what does he like to do? Does this inhibit him from working? Like, I've had patients who say, all I do is, sit and watch TV, and I don't really move much. And I have other patients that say, I'm a mail carrier,
Absolutely.
and I'm at danger of losing my job because I can't deliver mail.
Impacts their function more
Exactly,
or less. Yeah.
exactly. And so obviously 2 different types of patients. Generally speaking, we like to treat claudication initially with medical therapy and a walking program.
Yeah.
We teach them to walk as far as they can, and when they get that pain, walk a little bit further, and it forces their body to create collaterals, which can compensate for the blockage that they have. And I've seen patients on a walking program increase their ABI, the ankle brachial index. In this gentleman, it was 0.65, 0.68, and I've seen them increased into the 0.7s just by walking and without surgery.
I know you always hear about supervised exercise program. Like, what exactly is that? Because you hear about it, you read about it in test questions. Is that like something we can set up for patients, or?
That's a great question. I've only been here for 6 months, so I don't know exactly if that's set up here at Vandalia in terms of how formal of a work exercise program.
We'll
Dr.
cut that
Lee,
part.
can you comment
So,
on that?
I mean, I usually tell patients if you can get up and walk for 30 minutes 3 times a week, that's perfectly fine.
Perfectly
by me.
fine, absolutely.
For others, it may mean joining a gym,
Yeah.
being on the treadmill. Others, it may mean going to Walmart and
Yeah.
walking around. So I kind of work with the patient, but I let them know the baseline really that I would like for them to do is to walk for 30 minutes 3 times a week.
Absolutely, and that makes perfect sense. I mean, so
So there's no formal supervised
no formal,
program
absolutely,
here at Vandalia.
yeah,
I see.
yeah,
Yeah. I do a similar thing where I ask them to, if you know exactly that your mailbox is where it hurts, walk to your mailbox and then cross the street.
Yeah.
And then that's, force yourself to do that, to
make
gain
it
a little
into a
bit more, gain a
Absolutely.
little more distance.
So that's super helpful. So we're talking about aspirin, statin, kind of similar in the carotid stenosis case, talking about smoking cessation, diabetes control, and then for him a supervised exercise program. Let's say that he comes back to you, I don't know, a year later, and he's still having worsening claudication symptoms. Is this when you think about something like cilostazol or repeating an ABI? What kind of walk us through like what your guys' thought process is?
Yeah, so from my standpoint, I make sure they're on the aspirin, statin, smoking cessation, the walking program. I bring them back in about 6 months, and I tell them to call me if anything changes, if something worsens, develops a wound, and it doesn't heal. Common scenario we see is, I was clipping my toenail, clipped it a little too short, have a wound, now it's not healing, or I went somewhere and they were treating my bunion and then it didn't heal, things like that. So that's what we look out for. But let's say no trauma to the feet. I say come back in 6 months, we'll repeat your ABI, let's see if your ABI improves. We find, again, in claudication, there's 3 categories. A third get better, a third stay the same, and a third get worse. And so if Mr. J's coming to me saying, yeah, now I can't even make it out to my front door, or like, I'm trying to go to Disneyland with my family. I'm retired now. I want to go to Disneyland with my family, but, I can't enjoy time with my grandkids because I'm slowing down. That's when I talk to them a little bit about cilostazol or Pletal, which is a medicine that can vasodilate and allow them to have a little bit more perfusion. Some people respond well in terms of getting some walking distance. Some people say it doesn't do much. But at this point, this is kind of when I'm starting to think that maybe to improve his quality of life, I would maybe offer some endovascular treatment.
Absolutely. So
Yeah, I usually temper expectations by telling them about half the patients I give this to works great. About half the patients, there's really no difference that they can feel.
Absolutely.
And then some people just stop taking it on their own because of the side effects, so things like palpitations, or they feel like their heart's beating under their chest. So
that was really good. It's good to see both of your guys' perspective on, I know such a disease process like prevalent in our patient population. So is there a way for us to be able to differentiate, like whenever we hear lower extremity pain, we should be thinking PAD instead of, I don't know, something like neuropathy? Is it kind of like that classic exertional angina that you hear?
I mean, obviously, physical exam is very important, and I think that I stress that with all med students that I work with. Like, it doesn't matter what field you're going into, you need to learn how to check femoral pulses and pedal pulses. And popliteal pulses are maybe a little more esoteric, but at least the pedal pulses, and you can always ask someone on the floor to help you find a Doppler. It's a good exercise. But palpable pulses generally, and with pain, generally protect you from arterial disease or some sort of vascular emergency. I think it's really the paralysis that can be very scary for patients. And it's time to call a specialist to rule out emergency. Obviously, non-healing wounds they're not always an emergency, but definitely need more urgent attention in terms of revascularization.
I'd like to kind of ask them what kind of pain they're experiencing, because neuropathy pain is very classic. Things like burning, tingling. Some people would describe it in different ways. Like, it feels like I'm walking on glass. It feels like I'm walking on bubble wrap. It feels like someone's wrapping my foot in a towel and twisting it so it's making it tight. That's more of a neuropathy type picture. I also like to ask them, are there positions that you stand in or sit in that hurt too? So if you're standing in the kitchen doing the dishes, are you experiencing the pain?
I always have pain when I stand and do the dishes.
So if you're experiencing that type of pain even when you're not exerting yourself, like standing is not really exertion. So if you're experiencing that type of pain even when you're standing still, it makes me think a little bit of a different direction than maybe a vascular related issue.
That makes sense. So positional, the characteristic of the pain, all going to be important things. So that was extremely helpful. So really big things that we're taking away is differentiating the different categories of PAD. We talked about claudication versus rest pain, versus what was the last one, Dr. Go?
Tissue loss.
Tissue loss. The last one was leaving me. And then we talked about, again, just making sure that patients are on all the right therapies like aspirin, high-intensity statin. You talked about need for urgent revascularization being, the 5 Ps. So any other big takeaway points that you guys can think of?
No, I think that our team is always very open to education, and we're happy to see patients, even if you're questioning whether or not a vascular consult is appropriate. Don't be afraid to call us. We're happy to evaluate them. So,
thank you so much, Dr. Go, for joining us today.
oh, thank you.
For decades, we have performed the most complex heart and vascular procedures using groundbreaking technology and minimally invasive techniques with a team of more than 60 specialists. Don't trust your heart to just any hospital. CAMC is the region's #1 heart and vascular center for a reason.
Scheduling your primary care visit is just a click away. CAMC Primary Care and the CAMC Family Medicine Center now offer online scheduling. Book your appointments easily from home or on the go at your convenience. To schedule your appointment, visit camc.org/primarycare.
Mr. Smith is a 66-year-old male. Similar history to Mr. J that we previously talked, 40-pack year history, hypertension, hyperlipidemia. Also says he has a family history of cardiovascular disease. He is again coming to the primary care clinic for routine checkup. Says that he's been mostly asymptomatic, denying getting complaints today. During your physical exam, you palpate a pulsatile mass in his abdomen. He declines any abdominal pain, back pain, or any other associated symptoms. Vital signs are stable and has no history of prior imaging of the abdomen. Given his risk factors, being the good resident or attending you are concerned about the possibility of a AAA. You decided to order an abdominal ultrasound for further evaluation. The ultrasound reveals a 4.8 centimeter infrarenal abdominal aortic aneurysm. So same thing, Dr. Lee, we're just going to pause and take our colleagues take into account, like what's vascular surgery thinking when this gentleman walks into your guys' office?
Sure, yeah. So 4.8 centimeter aneurysm is a pretty good sized aneurysm, I'd say. The normal size of an aorta in a man is typically around 2 to 2.3 centimeters. And in women, they have natively smaller arteries, so maybe just slightly smaller than that. Aortas are typically categorized as an aneurysm once they're 1.5 times the size of normal. So if it's a 2 centimeter aorta that's normal, then a 3 centimeter aorta would be aneurysmal, or just larger than what
than
it should be.
Absolutely.
And then I usually have a very in-depth conversation about why aneurysms occur. And honestly, we don't have a good A causes B kind of explanation of why people have aneurysms. I tell patients sometimes it's family history, so it's genetic. Sometimes it can be it's definitely related to smoking. So
Absolutely.
Smoking can make aneurysms form. It can also make aneurysms grow faster than they should. And then sometimes it's just luck of the draw, I'd say. But very rarely there's other things like connective tissue disorders that may lead to aneurysm formation as well. But more commonly, it's something a patient is undergoing tests for, something else to find kidney stones or abdominal pain, and they do a scan, and lo and behold, they have an aneurysm, and they never knew about it because it wasn't causing any problems. Once it gets to a certain size, then we talk about surveillance. And I always talk to them about aneurysms being like a water balloon. So the larger the water balloon gets, the thinner the walls of the balloon get stretched. And what eventually can happen if it gets too big of a size is it can pop or rupture. So that's what we want to prevent from happening. So there are certain size requirements before we even think about doing any type of treatment. So 5.5 centimeters in men, maybe a little bit smaller than 5 centimeters in women, we would typically talk about doing some type of intervention. Mr. Smith has a 4.8 centimeter aneurysm, so it's not quite at the 5.5 centimeter rank, but usually around 4 to 5 centimeters in a man, I would do yearly surveillance with an ultrasound. If it gets to the 5 to 5.5 centimeter range, then I would do every 6 months, and we may change imaging modalities, like maybe get a CT scan rather than doing duplexes.
Wow, you just answered every question that I had for a follow-up, which is great, is great. So again, talking about that 4 to 5 centimeters, talking about yearly surveillance versus if it had been slightly bigger, increasing the frequency of monitoring. Gosh, that's such good things for us. And to know, ideally he would be in your office, established care, but sometimes these patients can slip through the cracks. Making sure that they have their follow-up appointments with you and making sure that we're screening patients. That's one of the biggest things too. 65-year-old male, what's the new recommendation? Greater than 100 cigarette smoke history?
So our recommendation, the National Vascular recommendations, we actually say any smoking history.
Yeah,
it doesn't
absolutely.
really depend on how much you smoke, but if you smoke and you're 65, you should get a screening ultrasound for a AAA. I also tell people if they have first-degree relatives who are diagnosed with a AAA, or if I'm seeing the patient, I see Mr. Smith, I tell Mr. Smith, your kids, your parents, your siblings, those people need to be screened for a AAA sometime in their lifetime. And then when we talk about surveillance, just to bring that back, I always tell patients aneurysms grow over time. That's what they do. So it's not abnormal for it to be larger on a follow-up visit, but the biggest important key characteristic that I look at is how fast it's growing. So if it's growing at a normal slow rate, then it's not something to cause alarm. If suddenly 6 months ago it was 4.8 centimeters and it grows more than a centimeter within a year, then I would be a little bit more.
That's something that's a little bit more concerning.
Exactly. Yep.
Absolutely. So, that definitely makes a ton of sense and kind of helps us take care of these patients. You kind of touch base on interventions in terms of in a patient with a known history of a AAA, and he's calling our clinic complaining of new onset back pain. This gentleman needs to go emergently to the ER. What is the next step in terms of like imaging modality that should be ordered? Like, what would you guys like to see?
Yeah, so if a patient has a known AAA and suddenly they're experiencing abdominal pain, pelvic pain that really kind of spreads to their back, one of the first things that you should think of is something's going on with the aneurysm, right? And the quickest test and probably the best test that we can get would be a CT scan. And there's special kinds of CT scans where we inject contrast, and it's called a CT angiogram or CTA. And that gives us a clear picture of really what's going on with the aneurysm itself, other surrounding structures, other blood vessels connected to the aneurysm and such. And I think if there's a symptomatic aneurysm, what are the things I'm looking for on a CT scan would be things like, is it leaking? Is there blood or contrast coming out of the aneurysm there shouldn't be? Sometimes you can have surrounding inflammation that you can see on a CT scan around the aneurysm itself that may be pointing to, hey, we should get this taken care of much quicker rather than later. So those are the next steps that I would take when seeing someone with abdominal pain or back pain and with a known history of a AAA.
That's super good. That really helps us too, especially seeing some of these patients in the emergency room or in the clinic. They have a known history of AAA, but they've got this worsening back pain. This is more, a sooner rather than later type of thing. So thank you for helping us with that. So you touched on quite a bit today. We are so thankful for that. You talked about screening, talked about the national recommendations on if you've ever smoked and you're at that 65 years of age and you're a male that you need screen. Then you talked about what is a normal diameter, and then you talked about when it would be appropriate for surgery. So thank you so much for that. And if you could tell your patients today one thing to stop their aneurysm from growing, what would it be?
You got to quit smoking.
You got it. That's always a test answer, right?
It's a test answer. It's a real life answer, and I'm very real with them. I say, I've never smoked before, so I don't know what it's like.
Absolutely.
But if you value not having stroke or not having peripheral artery disease or not having your aneurysm grow or even not having a heart attack, those real life problems, health problems that can kill you can be directly tied to smoking.
Absolutely.
So I would say the biggest thing is,
and that's where we too, I feel like we can kind of step in and help with that, whether it be through Chantix or Wellbutrin or nicotine replacement.
Absolutely.
So,
yeah.
But yeah, thank you so much. Gosh, I guess that's going to bring us to the end of today's discussion. I feel like we've covered a lot of important things from the ground of, well, I guess that's going to bring us to the end of today's discussion. We've covered a lot of important ground from, management of peripheral arterial disease. You talked about asymptomatic versus symptomatic carotid artery stenosis, and even about the importance of abdominal aortic aneurysms. So we're so thankful to be able to sit down with our vascular surgery colleagues and take care of these patients. So as primary care providers, we're often the first to spot these subtle signs that can change the trajectory of a patient's health. And working closely with our surgical colleagues is key to ensuring the best outcomes. So, again, Dr. Lee, Dr. Go, I just want to thank you for sharing your insights and your expertise. It's been a valuable conversation today that I'm sure will resonate with both clinicians and patients alike. As always, I hope this episode helps you feel more equipped in your practice to manage these complex cases and to know when to collaborate with specialists to get the best care for your patients. Thank you for tuning in, and we'll see you next time on Health Matters, where we continue exploring the intersection of primary care and specialty medicine. Until then, thank you for joining me on this journey toward better health.
Health Matters Today is a podcast recorded at Vandalia Health Charleston Area Medical Center Studios in Charleston, West Virginia. Hosted by Dr. Sheylan Spencer, directed by Dr. Amy Bruce, produced by Christopher Cobb and Jason Likens.